Speaker, it's Dr. S.Park from Rochester Mayo Clinic. He's going to talk to us about clinical SFRT and the lattice and grid SFRT.
We'll be talking about spatially fractionated radiotherapy. This is the outline of the talk. There's a case one, young lady, 26-year-old with malignant phloides tumor. You can see the size of the tumor causing pain symptoms and mass effect. And she had prior palliative radiotherapy, 39 gray in 3 gray fractions outside with no improvement in her symptoms. Actually got worse. So they asked for urgent surgical consultation for palliative mastectomy. Second case is a teacher who presents to the PCP with worsening upper respiratory symptoms, not improving with antibiotics, and the imaging showed a large mass in a lung, as shown on the CT scan here. Third case is a gentleman with 4-week history of erythema that progressed in 2 weeks to a large bleeding mass. Both those biopsies came back as BRAF wild-type melanoma. So why do we do SFRT at Mayo Clinic? It's a really good tool to have in your toolbox when you have no other options for these kind of cases. So what is SFRT? With the conventional radiation, we're usually treating the target with the margin so don't miss anything. But in SFRT, on purpose, we're just putting holes or pipes of doses depending on the technique. And that when that radiated lesion is about 1 centimeter, that's what we use in the clinic called grid and lattice. When they get to 0.5 millimeter, they're called Minibeam. And then another 10-fold smaller size is called microbeam. And as you go down in the size, the peak to value ratio goes up. Oops. So this is what the dosimetry looks like using the brass grid. It's just pipes of dose, a high dose, and they're falling off. And then there's VMAT lattice technique. At Mayo, we do random spear placement. At WashU, they have a geographic and geometric spear placement. And then we can also have proton grid. So the grid is not a new thing. It can go back to 1950s. This is one of the earlier papers I found. It's a pre-MB era, so it's all X-ray, ultra voltage. And they made a lead grid covered with rubber to avoid secondary electrons. And using this technique, they were able to deliver hundreds, let me say that again, hundreds of gray without much side effects. And some of these patients had a complete response. Now we move to the modern grid. We call it modern because it's now using 6x MV megavoltage. And this one had 71 patients with 8 centimeters or bigger tumors, most of them from lung, head and neck, sarcoma, and skin. As you can see here, they had 8 patients with definitive treatment and 4 had complete pathologic response. In terms of palliation, it was very effective at palliating, 80% response in pain, 100% response in bleeding, and the mass effect was also very good at response. So when we give, in terms of the response by dose, when you give SFRT, it looks like when you give 15 gray or more, you get a better response. I write small numbers here. And then when you follow that up with external beam, you get even better response with the higher dose, 40 gray or higher. So this was a recent publication in the Red Journal. 80 patients with 82 treatments. Half of them were treated as palliative intent. Most of these patients were head and neck. 62% were grid, rest were IMRT technique. And you can see the median dose, follow-up dose was 46 and 25. And the patients also had 44% had a systemic therapy on board. You can see the response rate is in the 82%, and we would not expect to do this with a standard 20 grain 5 or 30 grain 10. And not surprisingly, when patients were treated with definitive intent with a higher dose, they had better response rates. Moving to the lattice technique, this is a literature search, and they reviewed 329 papers. But if you take out the physics paper, clinical papers, abstracts, you're left with only 12 studies. of which 3 are prospective. So there's very, very limited clinical data, even though we have anecdotal data from different single institution data. This is the WashU technique that I mentioned before. It's a phase 1 study, including patients with 4.5 centimeters or larger. And most of them had had at least 1 prior chemotherapy. And again, you see 80% reduction by 3 to 6 months out after the treatment is done. Our experience was published a couple of years ago, but this is outdated because it went only up to 22. Now we have over 400 patients that are treated at our institution. Majority of them are sarcoma or non-small cell lung cancer. Most common sites are thorax and abdomen. And our median dose is 20 gray in 1. And vast majority of the patients had follow-up EBRT. You can see here again, the local control rate at 1 year is about 80%. Be careful, wary of the abdominal targets where how you place the spheres. This patient had a complete response, but eventually developed fistula. So we don't know if the mass had already eroded into the lumen or whether the sphere was placed incorrectly. There's also data for cervical cancer, 10 patients with very nice response. Proton grid is nice because there's no fall-off dose. You can protect the bowel. And this is a proton lattice technique shown by University of Maryland. So going back to our first case, young lady who didn't respond to palliative radiotherapy, they consulted our surgeon. And unfortunately, the surgeon called me and I said, do not operate on this patient. You're going to have positive margins, would not have to close the wound. She will die of sepsis. So we ended up giving the grid after the EBRT. And she started responding just weeks after the grid therapy. And at 3 months, she was able to go to surgery with negative margins. And the follow-up punch biopsies were all negative. So we achieved very good palliation for this young lady. Unfortunately, she passed away from systemic metastases. Our second patient, 59-year-old teacher with biopsy-proven BRAF wild-type melanoma. At this time, it was so large that Medon called me and said, we need to give some grid radiation. And they know how to order grid when they call me. So 20 gray in 1 with ipi-nivo, but due to ICI toxicity of hepatitis, she only got 2 cycles of this drug and then followed up with 20 gray in 4. And 3 months later, we went from this big mass to small. And then a couple of months later, she went to lobectomy, and we had complete pathologic response, and it's all necrotic tissue. And she was follow-up this past December, no evidence of disease after almost 3 years. This gentleman was also treated with the grid block and the follow-up EBRT and received 3 cycles of ipi-nivo. You can see the necrotic center. But with the rim enhancement, we weren't sure if that's residual cancer or epithelial tissue. So he went to surgery with reconstruction, again, pathologic complete response. And that's a photo of on this return visit. So these are the papers. If you want to learn about the lattice, we plan it in Mayo Clinic. And I just want to give an advertisement to this IAEA trial led by Dr. Soa Salem. This is now the data that we're trying to produce as a randomized evidence showing superiority of the SFRT over standard fractionation palliative regimen. Your support would be greatly appreciated for this trial. So now I'm going to turn our attention to Minibeam. Now these are research and arena. Our physicist Michael Grams developed this tungsten palmator where the opening of the slit is 0.5 millimeter. And there's preclinical data that's over 30 years showing that you can deliver hundreds of gray to the spinal cord and the mouse or rat brain, and there's no side effects. But these are very difficult to deliver because you need a high dose rate from the synchrotron, and there's only 2 in the world, one in France and one in Australia. So he said, well, let's try using our auto voltage kV energy at a dose rate of 2 to 3 gray per minute. And I said, is that going to work? So we did it on the mouse. When we did it on B16 melanoma, Up here is the primary radiated tumor. They all receive PD-1 therapy. You can see that 90% of the animals had complete response. And the abscopal tumor and the non-radiated flank, there was a 50% response as opposed to the other standard SFRT-like or hypofractionated regimen. And we analyzed the tumors using flow cytometry, and we see that in the animals that received Minibeam had higher adaptive and innate immune cells, including natural killer cells and dendritic cells, and less of immune inhibitory AM2 macrophages compared to the standard radiation. So we translate this into humans. This is a patient that we published as a case report. This gentleman had mucosal melanoma of the right mucosa, had multiple surgeries, recurred, multiple systemic therapy recurred. He had 45 gray and 15 fraction to basically hemi-face. You can see the eye, entire globe, lens, face was all in that field and failed. So basically no option. He was on fourth line tyrosine kinase inhibitor, was not working. His ECOG status was 3 when I saw him. He was losing weight and said, well, let's try this. So I gave 60 gray to the peak dose in 2 fractions. So 30 gray per fraction to the peak dose using a 8 cm cone prescribed to the surface. And lo and behold, just weeks later, he started responding. And you can see the primary responded, complete metabolic response. And this is the met that he had in the abdomen, and you can see the abscopal response. So we have a phase 1 trial that is ongoing at Mayo Clinic. We have 2 arms. Each arm is 30 patient cohort. We have intact skin cohort and a disrupted skin cohort because the endpoint of the trial would be different between the 2 arms. And we are at level 3. We just treated a valley dose of 5 gray, which translates to peak dose of 90 or about 100 gray, depending on the cone size. And that patient is also doing fine. So conclusion, the SFRT data is limited, but the anecdotal data does show that it is safe and efficacious. The technique is heterogeneous, especially when it comes to lattice technique. And therefore, really, we designed this trial at IEA, actually December of 24. We had a meeting out there and designed that trial. So that trial should be opening pretty soon. Dr. Sola is nodding yes. And we're hoping that we can enroll patients on that trial. Yeah, thank you very much.
7 minutes ahead of time, so we have time for questions. We have 7 more minutes.
Oh,
we have time for questions. Great talk. I have a very specific question, actually. We have been using in our practice central hotspots. So 90 gray, for example, in 15 fractions or 125, for example, for large liver tumors, like a central death trap. How does lattice differ from like multiple hotspots, right, within the tumor, differ from one single large hotspot? Is it from a radiobiology perspective, for example? And, you know, when you start your carbon ion program, do you see an application for lattice, or would you move more towards like larger hotspots, more targeted type of
so I think, let me rephrase your question, is that when we do like SRS or SFRT technique, we can make the center really hot, right? So before I knew about this technique, I had a young lady in her 30s with a huge abdominal melanoma, size of a basketball, in a thin young lady. So all I know, I was like, how can I palliate this patient? So it was all surrounded by bowel, right? Because you got this mass, and then the bowel is all surrounding this mass. So I prescribed 30 gray and 10, which is safe for the bowel. And I said, that's supposed to make sure just push all the dose in the center as hot as you can. So in the middle, if you get towards the middle of that mass, it was over 100 gray in 10 fractions. Nothing. She passed away. It did not work. Even though I gave 100 gray in the middle of that mass, it just laughed at it. So when we do these holes we are, I think, putting in these, because whatever is in the holes will die, right? But the low dose areas, I think that allows the immune cells to penetrate. I have data that I didn't show, but when we read the classic Hall textbook, it says all lymphocytes are radiosensitive. So if you give any radiation, all lymphocytes will die. Not true. If that were the case, none of us would be sitting here today. Okay, we get UV rays, and if the UV rays hit us and all our T cells die, we would not be here. So what I did was I took healthy donors of blood, peripheral blood. We radiated single dose, 2, 4, 6, 8, 10 gray. And yes, the T cells that are naive, that have not engaged this antigen, they're very radiosensitive. Even at 2 gray, they'll die. But if the T cells have been engaged with their antigen and they're mature, they will live through that up to 8, 10 gray, no problem. Similarly, regulatory T cells are very robust, right? So you got to stop the immune response. So the T cells, Tregs are also robust. They'll survive the high doses as well.
So how low do you go and how high do you go when you?
Yeah, that's the topic of research, right? What's the ideal peak to valley ratio? What's the valley that you need, and what's the peak, and then what's the ratio that's what we're researching through that phase 1 trial. Yeah.
Thank you.
Yeah, thank you.